Advize Health for our webinar on FQHC services. I'm your host, Maggie Stankowitz, and I'm pleased to welcome you to today's event. Before we get started, I want to give you a little bit of background on Advize Health. At Advize, we analyze processes, create protocols, and implement solutions for healthcare entities of all sizes. Advize Health has been in existence for over 12 years and employs the industry's top experts. We offer many services, including healthcare compliance analysis, medical documentation auditing services, and educational opportunities for a number of topics, including ICD-10 training and clinical documentation improvement. Our priority and promise to the healthcare community is to always tailor our services to our clients' individual needs and to provide cost-efficient services that every entity is able to afford. We have two exceptional speakers for today's presentation, Christina Martin and Danielle Bugbee. Ms. Martin is a client project manager for Advize Health. Ms. Martin provides quality auditing project management services. She has 17 years of experience in the healthcare industry, with a majority of those years being a certified professional coder from the AAPC. Throughout Ms. Martin's career, she has served as a project manager for dental audit experience and has performed various roles in physician practice management, office management, and family and pediatric practice settings. Ms. Bugbee is a dental auditor for Advize Health. Ms. Bugbee provides coding combinations for proper payment of benefits, insurance appeals, and diagnosis coding. Previously, she was a practice administrator for a dental practice, as well as an insurance coordinator for a separate medical practice. She has 20 years of dental and medical experience. Today, they will be focusing on FQHC services and lookalike entities. If you have any questions throughout the webinar, be sure to submit them via the questions or chat text box in the GoToWebinar interface and send them to all organizers. I'll make sure that Christina and Danielle have time at the end to answer some of your questions. You can expect to receive an email with your certificate for 1.5 CEUs, a copy of the presentation, a recording, and a transcription of the Q&A session 3 to 5 business days after the webinar. I'll now turn it over to Danielle, who will begin the presentation on FQHC services.
Thank you, Maggie. Good afternoon. The goals and objectives for today: what is FQHC, its importance, the services, advantages and disadvantages, challenges auditing and reporting FQHC versus traditional plans. We'll discuss a case study, other FQHC information, and we'll have time for additional feedback and questions. Moving on to the next slide. Information regarding FQHC can get confusing. Our hopes today is to give you a clear understanding of how this program works, who it serves, and clear up any conflicting information. What is FQHC? Federally Qualified Health Center. The main purpose of FQHC program is to enhance the provision of primary care services in medically underserved, vulnerable, urban, and rural communities. FQHC offers supplemental family support services such as interpretation and transportation and provides comprehensive primary preventative health and dental services to all persons of all ages regardless of their ability to pay. There are 4 types of FQHCs: community health services centers, migrant health centers, provide comprehensive and cultural competent primary health service to migratory and seasonal farm workers and their families. Additional focus of this program are on prevention and occupational health and safety, healthcare for homeless centers, serve patients who live on the street in shelters or in temporary housing. They provide comprehensive health care services that include substance abuse and mental health. Public housing is a primary care center, provides residents of public housing access to comprehensive primary care services. Often these services are provided on the public housing premises or within easy access to residents. In recognition to the unique challenges and barriers to care faced by certain special populations, some centers receive specific funding to focus on serving these groups. These populations experience additional challenges, including high levels of mobility, language, cultural barriers, geographic and social isolation, and substandard living conditions, just to name a few. Moving on to the next slide, we're going to talk about HRSA and PHS. These are two entities that we're going to discuss within the next few slides. HRSA, Health Resources and Services Administration. HRSA is an agency of the Department of Health and Human Services and primary agency responsible for improving health and achieving health equity through access to quality services. HRSA's role in the FQHC designation process is to determine which sites are eligible to apply to Medicare and Medicaid to become FQHC providers. HRSA oversees and maintains databases that protect against healthcare malpractice, waste, fraud, and abuse. HRSA's goal: improve access to quality care and services, strengthen the health force, build health communities, improve health, strengthen HRSA program management and operations. Tens of millions of Americans qualify for this program. Moving on to the next slide, HRSA has a vision and a mission statement. Their vision is healthy communities, healthy people. Their mission statement: to improve health and achieve health equity through access to quality services, a skilled health workforce, and innovative programs. A website has been added here to the slide deck if anyone would like to take a further look at the vision and the mission statement. Moving on to the next slide, we'll be going into PHS Section 330 Act. This is a brief definition. Health centers must service a population that is medically underserved, be comprised of majority and seasonal agricultural workers, the homeless, and residents of public housing. Must provide staff in supporting researches of the center or through contracts or cooperative arrangements, health services related to family medicine, internal medicine, pediatrics, obstetrics, gynecology, that are furnished by physicians and, where appropriate, physician assistants, nurse practitioners, and nurse midwives. In order for the healthcare center to receive approved funding, they must also follow requirements of the PH Section 330 Act. Use of these funds may include the purchase or lease of equipment, which may include data information systems, and interest on loans for equipment, reimbursement on other activities that promote the development of practice management or managed care networks and plans. You will see we've added a section in which the information can be found, Title 42, Chapter 6A. Moving on to the next slide is the PHA Section 330 Basic Need and Service. The need assessment. Health centers and documents the needs of its target population, updating its service area when appropriate. Required and additional services. Health center provides all required primary, preventative, enabling health service, and additional health services as appropriate and necessary. Moving on to the next slide. PHS, the basic requirements. Staffing requirements. Maintain a core staff as necessary to carry out all required primary preventative services. Accessible hours of operation. Provide services at times at locations to ensure accessibility that meets the needs of the population. After hours coverage. Coverage for medical emergencies during hours when centers are closed. Hospital admitting privileges. Physicians must have admitting privileges at one or more federal referral hospitals. Sliding fee schedules. Have a system in place to provide and determine eligibility for patients' discounts, adjusted on the basis of the patient's ability to pay. No patient will be denied healthcare services due to an individual's inability to pay. Quality improvement maintains clinical service management and the confidentiality of patients' records. Management and finance. Fully staffed health center management team appropriate to the size and the needs of the center. Contractual affiliation agreements. Oversight and authority over all contracted services. Financial management of control policies. annual independent financial audit is performed in accordance with federal audit requirements, including corrective action plan addressing all findings. Billing and collections, maximizing the collections and reimbursement. Budget, the budget that reflects costs of operations, expense, and revenues. Program data reporting system, accurately collects and organizes data for program reporting and management to support decision making. Moving on to the next slide, we're going to talk about FQHC requirements. To be certified as an FQHC, you must meet one of the following core requirements. Is receiving a grant or funding from such a grant under Section 330 of Public Health Services. Is operating as an outpatient health program or facility of a tribe or tribal organization under the Indian Self-Determination Act, or as an urban Indian organization receiving funds under Title V of the Indian Health Care Improvement Act as of October 1991. Please note that the facility is not receiving a grant under Section 330 of PHS Act, but is determined by the Secretary of HHS to meet the requirements for receiving such a grant based on the recommendation of Health Resources and Services Administration. The entity qualifies as a FQHC lookalike, which we will talk about later in this presentation. Basic definition: funding opportunity for organizations to provide care for underserved populations. Benefits include funding to help with the cost of uncompensated care and federal loan guarantees for facility improvement projects. Direct funding comes from HRSA, which we just discussed in the previous slide. Moving on with more requirements for the FQHC. In addition, the entity must meet all of the following requirements. Serve as an underserved area or population, offer sliding fee scale for persons with incomes below 200% of federal poverty level, provide comprehensive primary care services for all age groups, have ongoing quality assurance programs, be community-based with majority of governing board of directors comprised of their patients, offer services to all persons regardless of their ability to pay, and be a nonprofit or public organization. Moving on to the next slide of requirements continued. They have to meet other health and safety requirements, not be concurrently approved as a rural health clinic, must provide preventative health services on site or by arrangement with another provider, including dental services, mental health and substance abuse services, transportation services necessary for adequate patient care, hospital and specialty care. They must provide services at times and locations to meet the needs of the populace being served and record their hours of operation and current scope of project. Moving on to the next slide. This gives you an overall of participating sites. There are 434 participating sites involved in the FQHC Advanced Primary Care Practice. The link below will help you view an interactive version of participants of FQHC primary care service practices. The effectiveness was tested by CMS in partnership with HRSA, with participating FQHCs were expected to achieve Level 3 patient-centered medical home recognition, help patients manage chronic conditions, as well as actively coordinate care for patients. Reaching and serving hard-to-reach populations successfully requires effort. Each health center, led by its board of directors, identifies and implements strategies to address these challenges. These may include community outreach, mobile services, language access strategies, partnerships with other organizations, use of lay health workers, appropriate screenings and services, staff cultural sensitivity training, and appropriate adaptation of clinical recommendations, among others. I live in Florida, so I did a little research, and I noticed in 2013, Florida Health Centers served 54,000 migrant and seasonal farm workers and over 76,000 persons experiencing homelessness. Moving on to the next slide. This chart is broken down by percent by income level, percent by insurance status, percent of ethnicity, percent known to race. Column 1 is health center programs. Column 2 is the U.S. population. Millions of Americans are members of the health center program. Health centers serve all ages, from children to the elderly. They also serve both the insured and the uninsured. The rates of uninsured patients was climbing steadily between 2001 and 2009, but the expansion of Medicaid is likely to reduce these numbers drastically in the coming years. More of this will be covered in the next slide. Note in 2009, 71.4% of all patients served by health centers were at or below the poverty line, and 38.2% were uninsured. Moving on to the next slide. To speak more about underserved populations that the FQHC cater to, we have a graphic here that illustrates the insurance coverage demographics between the historical 2009 and the projections for 2019. In 2009, a little over 38% of patients treated in health centers were uninsured. This is a staggering amount of uninsured patients, but luckily through insurance exchanges and Medicaid expansion, the rates of uninsured patients is steadily declining. By 2019, we predict the numbers will be down about 15%. Other sources of payers will shift only marginally compared to these Medicaid-centered changes, and we have a good idea on how FQHC payers will be reimbursed within the next 3 years. Moving on to the next slide, we're going to discuss some FQHC services and what's included. Physician services, services and supplies incidental to services of physicians, nurse practitioners, PA, CNM, CP, and CSW services. Services and supplies incidental to services. Medicare Part B covered drugs furnished by the incidental to services of an FQHC practitioner. Visiting nurses services to the homebound in the area where CMS determined there is a shortage of home health agencies. Outpatient diabetes self-management training, nutrition therapy, and patients with diabetes or renal disease furnished by qualified practitioners. Interpretation services are also provided to these with limited English proficiency. Moving on to the next slide, FQHC visit definition. Medically necessary face-to-face medical or mental health visit or qualified preventive health visit between patient and a physician, during which one or more qualified FQHC services are rendered. Transitional care management and advanced care planning are considered FQHC visits. In limited situations, a visit by an RN or LPN to a homebound patient qualifies as an FQHC visit. If these services are furnished on the same day as an otherwise billable visit, only one visit is payable. Please note that as long as the patient is seen, it is billable, but it is not if it is not medically necessary or within normal practices. Moving on to the next slide, FQHC visit qualified locations. The locations are the FQHC facility, the patient's residence, a Medicare-covered Part A, SNF, the scene of an accident. FQHC visit non-qualified locations are inpatient or outpatient department of a hospital, including critical access hospital, or a facility that has specific requirements that preclude. Note if the administrative vaccines are furnished as part of the encounter, including the vaccine charges on the claim. If the administration of the vaccine is the only service furnished that day, do not file on the claim. Notice here, FQHC qualified locations offer free vaccinations and need to be reported on a separate worksheet. However, if the vaccine is the only service provided, no claim is filed. FQHCs receive 100% reimbursement for these costs at annual cost settlement. The patients pay no Part B deductible or coinsurance for these services. Moving on to advantages and disadvantages of being an FQHC. We're going to start with the advantages. Per visit bundled payment based on historic costs for services provided under Medicare, reimbursement under prospective payment system or other state-approved alternative payment methodology for services provided under Medicaid. Eligible to purchase prescription and non-prescription medications for outpatients at reduced cost through the 340B drug pricing program, access to vaccine for children program, automatic designation as a health professional shortage. The designation provides eligibility to apply to receive National Health Service Corp. Personal and eligibility to be a site where a J1 visa physician can serve, eligibility for various other federal grants and programs. Medical malpractice coverage is provided for the health center organizations, their employees, and eligible contractors under the Federal Tort Claims Act. In addition, the 330 grant funding, this capital can reach up to $650,000 for new starts, and it remains the primary financial resource for most FQHCs. Moving on to any disadvantages of being an FQHC. In general, must meet strict certification requirements, offer or contract out specific services, be governed by a board comprised mostly of patients. Physician's perspective, patients are not usually health educated and are likely to have high rate of noncompliance, high burden of disease, which can be a pro or con depending on the individual's perspective. Physicians performing residency at FQHCs have lower pay. However, they will likely qualify for federal NHSC loan repayment. Referring patients is harder as patients will likely have Medicaid, Medicare, and or no insurance, making it harder for them to see specialists. No control over staffing, hiring, firing, or patient population. Christina is going to take over from here and discuss FQHC billing and coding.
Thank you, Danny, for all of that wonderful information. So let's talk a little bit about billing and coding for FQHC. You can see here, it must be medically necessary with any medical or mental visit or qualified preventative health visit. Must be a face-to-face with qualified practitioner who perform an FQH service. Visit may be between homebound patient and RN or LPN under certain conditions. The PPS, Prospective Payment System, is designed to reflect all costs for services associated with comprehensive primary care visits, even if not all services occur on the same day. There's also a standalone billable visits, which are typically E&M services. According to the OIG 2016 work plan, the OIG services looks at medically necessary services consistently. So I thought that was a very interesting fact that also the OIG also looks at medically necessary services continually. We're going to now also look at understanding the prospective payment system. The PPS is the primary method of the payment for the services providing for FQHC services. Reimbursement methods are like Medicare payments for healthcare services, including dental, are made based on a predetermined fixed amount. Fixed amount is established and updated as necessary based on a formula and the actual cost of the services. This is considered it's called the PC Pricer application. Within the PC Pricer application, the files contain logic used by the FQHC Pricer program to calculate the PPS rate. They also take into consideration the geographic adjustment factors, and you can see below I provided just kind of a picture of the different geographic rates. Now let's talk about some of the G codes used in the FQHCs. So the FQHC must use the following G codes when submitting claims to Medicare under the PPS. The G0466 is utilized for a new patient. Note that one or more FQH services are rendered and include the FQH services as a bundled payment. So you can have one or more service underneath that new patient. The G0467 code is a face-to-face encounter as well, but is an established patient. A new patient is one who has not received any professional medical or mental health services from any site within the FQHC organization within the past 3 years. Only use G0466 if the beneficiary is new to the FQHC or any of its sites for any professional services. We're going to continue with some additional G codes. The G0468, this is for an initial preventative physical examination or an annual wellness visit. This typically is a bundled service and is on a per diem rate per patient. The G0467, these are the mental, 469, excuse me, and then 470, both mental health encounters. For the G0469 and the G0470, the mental health encounters codes, you want to use those as the same thing as you would for the medical services, as a 3-year basis, the G0469 being the new patient and then G0470 as the established patient. And the 3-year rule still applies. Let's look at a few examples for coding for the G codes. These are 2 different examples. So take the first example. G0466 is for a medically necessary face-to-face encounter and is one-to-one. So they're seeing that. So when you have the new patient is also receiving a mental health visit on the same day, you would code the G0466 for the medical and the G0470 for the mental. So one can be considered for the new patient and one is going to be considered an established patient. If an established patient also is receiving a mental health visit on the same day, the FQHC can bill for 2 visits and should use the established patient codes, G0467 for the medical and the G0470 for the mental health visit. Danielle, would you like to discuss the new code for 2016?
Yes. Effective January 1st, 2016, the CPT code 99490, Chronic Care Management, was added. It is paid based on the PFS National Average Non-Facility Payment Rate. And the CPT code 99490 is billed alone or with other payable services on an FQHC claim. When reporting the standalone code billable visit, an FQHC payment code is not required. Please make note, providers cannot bill for the new 99490 code in addition to transitional care codes 99495 and 99496, or for patients who are in hospice, end-of-life, or end-stage renal services, or receiving care coordination services. This is an updated code, Chronic Care Management, has been added to the new Medicare Physician Fee Schedule that was released by CMS. 75% Medicare dollars are spent on patients with 2 or more conditions. The new schedule allows primary care providers to receive additional payments for chronic care conditions and telehealth services. The new code shows that Medicare is continuing to emphasize the importance of care management. Moving on to the next slide. This is a list with the 9949 codes and what activities they can be used for. Development of care plans, monitoring of systems and outcomes, medication reconciliation, reviewing self-management goals, confirming participation in recommended or planned services, participating in caseload consultations and psychiatric consultations, coordinating treatment with PCP outside the community provider. Behavioral health professionals include social workers, psychologists, nurses, or medical assistants. Chronic care management services that occur outside of a face-to-face visit for patients with 2 or more chronic conditions, including depression and anxiety. The primary care provider does not need to perform the services. Non-face-to-face care coordination services can be billed when performed by behavioral health professionals. Some of the above were eligible for payments before. The new code allows for payments even if management is done over the phone, non-face-to-face. Patient follow-up occurs mostly over the phone. This change will encourage care managers and patients to adhere to treatment plan and future appointments. Moving on to the next slide. These are some quick facts about the code 99490. The CMS rate for 99490 is $40.39 every 30 days for each patient as long as they have 20 minutes of care coordination. Code billed must be supervised by an eligible provider of a psychiatry or primary care. Patients must have a minimum of 2 chronic conditions expected to last at least 1 year. Chronic conditions must place patient at risk of significant impairment or death. Providers are required to have an electronic health record and a documented comprehensive care plan. Patients must have access to round-the-clock care and be able to coordinate care with providers. Electronic care plans need to clearly delineate responsibility among providers, be able to describe coordination of care with internal, external providers, self-management goals, clinical goals, and medication, address each diagnosis updated as appropriate. Eligible patients can only receive services from one eligible provider at a time and must pay any costs or copays required. Christina is going to take over here and discuss payments, reimbursements, and OIG.
Thank you, Danielle. So let's take a look and do a comparison of a Medicaid and an FQH service. So here we have a comprehensive dental visit, new or established. On Medicaid, they could possibly charge out $25. For a child prophylactic, they would also get paid $30. So a Medicaid provider would then totally receive a payment of $55 versus the FQHC facility payment would receive $384. FQHC payments are for all the services rendered to the patient for the same day. Caring for the underserved urban and rural communities, there are challenges that come with getting the patients into the office and receiving the necessary care for their needs and for the dental care. You can notice here the concerns are that you look at is, could they possibly break these out into 2 different services? That would mean that they would receive a total payment of $768. As you can see from that significant difference, the FQHC payments take into consideration all services once again. So they need to probably do more. They could see medical, not just dental, within that data service. There's a potential for abuse with an attractive payment with the FQHC facility is receiving. Let's look at some red flags for FQHC benefits. It may be considered fraud if a healthcare center site submits a claim using a billing number from a different site, even if both sites are part of the same larger organization. Penalties do include, but are not limited to, repaying Medicare all reimbursement received for those services and billing expelled from the Medicare program and from being expelled from the Medicare program. Healthcare centers have 30 days to report any change to their board members to CMS, and they also have 90 days to report their changes such as address and licensing information. Failure to report these changes into the requirement timeframes could cause an FQHC to be denied the right to participate in Medicare. An FQHC OIG report that came out February of 2016, the OIG conducted an audit of an HPM Foundation. It's a nonprofit FQHC facility. You can see below that I've provided a link to the details to this report. Interesting facts is that HPM partially agreed with the OIG's findings that they did not provide reliable data on patients served in its USD report for the years 2012 and 2013. HPM stated that the total number of patients reported in this report was correct. However, the supporting documents provided to the OIG did not match because the data used to prepare the reports were corrupt and incomplete. So they did partially admit. And you can see the details. I provided that link below to this report. Now we're going to look at a case study. An FQHC dental case study. So this FQHC, which had multiple facilities conducting dental services, was identified as an outlier for possible excessive dental services. An in-depth comprehensive review was conducted for these dental services. The findings of this audit revealed excessive services being billed and rendering services that were not medically necessary. You can see the outcome that led to identify close to $3 million in overpayment. Some of the error codes utilized when reviewing an FQHC facility. You can see this list below: excessive visits, which I mentioned in the previous case study, not medically necessary, which was also referenced. And some of the other ones are insufficient documentation. The documentation doesn't support the service, or it's missing from the record. Non-covered service, the service performed then documented, is not covered under a benefit underneath that program. And a non-eligible provider, the service is not provided by an eligible or credentialed provider. Also, I noticed an OIG FQHC dental service report. Most children, I thought this was very interesting because we just did a case study and looked at some case studies there that showed that, there was some fraudulent excessive services. You can note that this report, most children within the Medicaid in 4 states are not receiving the required dental services. So 4 states, the 4 states that were looked at were California, Indiana, Louisiana, and Maryland. And only 2 had policies that did not allow payment for particular services in accordance with an established schedule. So based on the studies, you can see that 78% of those children were not receiving appropriate dental care. I also provided the link below for further details of this report. Danny, will you now discuss FQHC lookalikes?
Yes, ma'am. Okay. Lookalike organizations can be very confusing. We wanted to take a small look at this and to explain what these particular organizations are, what benefits they receive, and their requirements. We're going to move on to the next slide and take a glance at lookalikes. Federally qualified health center lookalikes are community-based healthcare providers that meet the requirements of HRSA Health Center programs but do not receive health center program funding. They provide primary care services in underserved areas, provide care on a sliding fee schedule based on the ability to pay and operate a governing board that includes patients. These organizations do not submit applications to HRSA or PHS Section 330 and must meet all requirements to participate in this program. However, they do not receive grant funding, but do have some similar benefits as FQHC, and may receive special Medicare and Medicaid reimbursement. Moving on to the next slide, we're going to look at some requirements of the FQHC lookalike organizations. They must be a public or private nonprofit entity, including tribal faith-based and community-based organization, be independently owned, controlled, and operated, provide comprehensive primary medical care as primary purpose, provide services either directly on-site or through established arrangements without regard to patients' ability to pay, serve a defined geographic area, medically underserved area, or medically underserved population, access to services for all individuals in area, provide services at one or more permanent full-time service delivery sites, be operational with all health center program requirements for at least 6 months. HRSA requires health centers program look-alike. Wanting to renew must do so every 3 years and certify their destination annually. Moving on to the benefits of look-alike organizations. Although look-alike organizations do not receive funding, they receive similar benefits. Cost-based reimbursement for services provided under Medicare, reimbursement under prospective payment system or other state-approved alternative payment methodology for services provided under Medicaid, eligible to purchase prescription and non-prescription medications for outpatients at reduced cost through 340B drug pricing program. Patients have access to federal vaccine for our children program at no charge for either the vaccine or the delivery, which we touched on earlier. They fall under safe harbor under federal anti-kickback statute for waiver of co-payments to extend a patient that is below 200% of the federal income poverty guideline, therefore entitling a discount based on the health center's application of its scheduled discount. Reimbursement by Medicare for first dollar of services rendered to Medicare beneficiaries, meaning deductible waived. Moving on to the next slide. Well, we are going to wrap up this particular webinar. There is no lack of information on federally qualified health centers. However, what's out there is hodgepodge of confusing, sometimes conflicting information that often leaves more questions than answers. We have endeavored to point you in the right direction to answer your questions, and we've included links to trusted resources to supplement the information on our site. Thank you.
Thank you for that informative presentation. We're now going to go over a few questions. If everybody hasn't sent in their questions to all organizers, feel free to do so now. One of our first questions is, what is the PPS rate for my FQHC?
Oh, that's a great question. There is one national PPS rate for all FQHCs. The rate from January 1st, 2016 through December 31st, 2016 is $160.60. Rates are subject to change annually in order to accurately reflect inflation. Rate changes often go into effect the first day of every year.
Thank you. Another one we have is in reference to slide 23. Could someone please provide clarity on what a CHC is?
Yes. I'm sorry, Maggie. Will you repeat the question? I'm so sorry.
Of course. On slide 23, we mentioned a CHC. Could we just clarify what CHC stands for, please?
Yes, that is the, I think it's an abbreviation for the actual healthcare centers, and that's found in Title 20, that's Title 42, Chapter 6A.
Thank you. We have a question here that asks, if a patient is seen in another unaffiliated FQHC and then becomes a patient in my FQHC 6 months later, are they still considered a new patient?
Yes, as long as the patient is new to your facility, they are to be considered a new patient.
If a FQHC is part of a county health department and a patient visits a health department clinic that is not a part of the FQHC before visiting a health clinic that is FQHC, would they be considered a new patient in regards to Medicare FQHC PPS adjustment?
Oh, that's awesome. Actually, yes. Any services provided outside the FQHC affiliation are not considered FQHC services. The patient is considered new because they were not treated prior in an FQHC facility, regardless of the health department affiliation.
Thank you. Let me take a look here. We have a few other questions that aren't necessarily related to FQHC about the speakers. Our speakers for today are Christina Martin and Danielle Bugby, and both are certified professional coders and auditors here at Advize Health. That appears to be all the time we have for questions today. Any additional questions will be answered when our handouts come out in 3 to 5 business days with a transcription of the Q&A session. If anybody on the panel doesn't have anything additional to say, we can conclude this presentation.
Great. Thank you for having us today.
Thank you so much.
Yes, thank you.
Thank you. Have a good afternoon, everyone.